President George, fellow Rotarians and guests, it's always enjoyable to introduce a speaker, especially when it's a longtime friend and colleague. Brian's a cardiologist who practiced here in Medford for almost 45 years, and after several attempts at doing so, he finally managed to retire the end of last year. And it occurred to me that there might very well be a few hearts in this room today that he has tinkered with over the years. Years ago, he decided there might be better ways of taking care of people who are having heart attacks. That's AKA myocardial infarctions. He worked on that for years, and he's developed a model that is now being used for the treatment of patients who are having heart attacks, not just here, but nationwide. Today, he's going to tell us about some of the changes that have happened in taking care of patients with heart attacks. Please give a warm Medford Road Rotary welcome to our speaker today, Dr. Brian Gross.
Well, thank you for having me. I love giving these talks, especially to Rotarians, because I have a special connection to many of you. What we have here is an interesting circle. There's the state of Jefferson STEMI program. STEMI just stands for the worst kind of heart attack. It's when the artery completely blocks off. And a little basic anatomy. The heart is a complex pump, but it's basically an engine. It's got 4 valves, 4 chambers. There's a low pressure pump and a high pressure pump, a couple gas tanks, a bunch of fuel lines. It has 100,000 heartbeats a day and 60,000 miles of blood vessels in every one of us. If we took every blood vessel out of you and put it end to end, we could wrap it around the earth 2.5 times. That's a lot of plumbing, okay? And so to start, everything builds on what went before. But in 1628, William Harvey, basically dissecting several-day-old cadavers, was able to figure out that there seemed to be arteries and seemed to be veins. This wasn't an active dynamic thing. This was a decaying body, and felt that there were 2 pumps. You had kind of one going to the lungs and one going to the body. He never quite was able to see the connection because he didn't have a microscope, but a microscope half a century later showed that there were these small capillaries that completed the loops. Not much happened until 1896, when at Dartmouth, the very first medical x-ray was done. I take personal pride in this because 4 of our 20 cardiologists have done some of our training at Dartmouth. There's a tiny little fracture down there that you can see. It was the first x-ray. And obviously things have expanded dramatically since then. Moving on, about 24 years or so, the first EKG. And this is what a STEMI looks like, kind of that big cove upward contour, affectionately known in the business as tombstone ST segments. And he put his name to it. And that's what the first electrocardiographic machine looked like. Here's what I use right now for my electrocardiographic machine, okay? The very first heart catheterization was done by this German, Werner Fossmann. He took a Foley catheter, which they were using at those times. He had this idea. He did a cut down on the vein in his elbow and threaded this thing up without any assistance. He had measured how far it would go. He walked up 2 flights of stairs, took an x-ray, and it showed the catheter in his heart right where he thought it should be. He was so proud, he walked into his boss, who promptly fired him. But that was the first heart catheterization ever done. This is one of my favorite slides that I put together. President Eisenhower, General Eisenhower was, on both tickets. Republicans and Democrats both wanted him. Several years into his first administration, while playing golf out in Colorado, he developed some rather significant chest discomfort, enough so that he went home, went to bed, got up in the middle of the night. Mamie, his wife, was concerned. They called Fitzsimmons Medical Center, sent a doctor over, said, just heartburn, probably from the onions on your hamburger. 24 hours later, he was still having discomfort, was not doing well. They came back and they diagnosed him with a myocardial infarction, a heart attack. So it was 12 hours, total almost 24 hours before something was done. In 1955, there was zero treatment for myocardial infarction. You could put them in an oxygen tent. You could give them amyl nitrite, which is like a nitroglycerin, but it doesn't reverse the heart attack. It just drops the blood pressure. Or you could give them morphine. You could treat the pain, and they either lived or they died. And 25%, 1 out of every 4 people who had a heart attack in the 1950s died in the hospital. The stock market took the biggest tank it had taken since the Depression. They brought this guy, Paul Dudley White, out from Boston, and he, after watching him for a day or two, went on TV and announced that President Eisenhower had had a bowel movement, which at that time, having regular bowel movements was considered a sign of good health. He spent 4 weeks in the hospital. We now get people out after a heart attack in 2 days. He was golfing postponed for 5 months because it was thought that the golfing activity was going to contribute to this. And they put you to bed and you wouldn't be able to do anything. Now we get him up into cardiac rehab. He had a small stroke while in the second administration. He wound up having 7 more myocardial infarctions, 14 cardiac arrests where his heart stopped and they got it going again. He spent the last 9 months of his life in Walter Reed Hospital in congestive heart failure. He had some of the first defibrillations and medications used. It was at about this time that the Framingham study came out and we were able to override the tobacco lobby that cigarettes were not good for you. They kept the cigarette lobby, the tobacco lobby was saying it was the coffee, but people were smoking and drinking coffee. So the president who warned us of the military industrial complex, in my mind, sowed the seeds for the medical industrial complex. If this can happen to the most powerful, revered man in the world, we need to do something. And at that point, pharmaceutical industries, device industries, all sorts of things kind of kicked into gear. And we saw the 60s and 70s start to develop. There was research done with heart catheterizations, and this guy, Mason Sones, was doing heart catheterizations, did the first coronary angiogram where he was able to shoot and take a look at what the artery looks like. Eugene Brunwald at the NIH. This is my boss when I first went out into Seattle, and he did a lot of the original work with congestive heart failure. I have my twins there. Congestive heart failure is very common. It can be big boggy hearts that hardly squeeze, tight little thick hearts that squeeze rigorously, but fluid can back up behind the heart. Bob Bruce I was his last cardiology fellow. He's the Bruce Protocol treadmill. The original ICUs, they weren't even ICUs, they were wards. And about the time in the early 60s, a couple places said, if you're having a heart attack, you need kind of a special place to recover. And here's what a coronary care unit might look like now. Paramedics were part of this heart attack treatment program. And that was the original paramedic unit. They would use the local hearses to take people to the hospital. Now I trained with this guy in the center, Len Cobb, who set up the first major paramedic unit up in Seattle. And of course, now we have Mercy flights and ground and air, all sorts of capacities that we didn't have before. The very first valve replacement done right up there in Portland by Dr. Albert Starr with his named, these are the Starr Edwards valves. And you can take a look here. This is what a normal valve looks like. Let me go back one here. And that's what a disease valve looks like. This is the artificial valves put in a tube so you can see how they're working 100,000 times a day. And then we have all sorts of variations on the valves now. First heart surgery, the Weinberg procedure was that they just take an artery and just stick it into the heart. And they were convinced that it worked until my boss, Len Cobb, did a randomized study where they opened up the chest and they wound up putting it into the heart, and the others, they just tie it off and they had the same result. So overnight, the original open heart surgery disappeared. It was not effective at all. It was a placebo effect. But then there were subsequent surgeries that were done where they would put a little tube in one artery and stuff it into another, an artificial tube. Then there was one who took the main artery and sewed it into another artery. And finally, Rene Favalero from Argentina, while at the Cleveland Clinic, harvested a vein and sewed it into the artery. That's the anastomosis right there. And the picture was taken about a week later and showed that it was open. So it revolutionized. Here's another fellow from OHSU, Daughter, kind of a wild guy. Okay, you can look at the expression on his face, but he had this 82-year-old woman who had a gangrenous foot, and she said, no way am I going to have an operation to repair that. He had been experimenting with any kind of wire, piano wire, coat hangers, whatever you want. And he has the Daughter effect, where he would just put it down that vessel, and what we bougie it, we call it Daughter effect now. And so here was the person who had the bad toe, and it healed, and she left the hospital. And there was the original blockage right there, and it opened up. Melvin Judkins was at OHSU. He was the fellow who developed those catheters. We use all those catheters every day in the cath lab right now. And then, of course, you got Steve Jobs. Creation is messy. You want genius, you get madness, two sides of the same coin. So here's Minor Matthews. Okay, Bud, you know him. Minor opened up the cath lab when he got here in town in the 1970s with Steve Fredrickson there. I love this picture. Minor had a green Porsche, and before they put a patient there, they had a big yellow lab that they wanted to practice. Is the X-ray going to work? Can we get catheters up there? So they had a dog, and they did the dog lab, and they resuscitated the dog at the end. And they took him back to Ashland. And while they were driving back to Ashland, as the dog was coming out of anesthesia, it had an explosive bowel movement in his car. There is our cath lab now compared to the original cath lab in 1973. And I'll show you this little video. This is an electrophysiology lab with David Martin doing. You can see we got a nurse doing the medications, an anesthesiologist hooked up all of the stuff. You got Dave Martin there working with Buck Sarver, looking at all the monitors. Here's the various catheters we're putting in. And he's doing an ablation study, a very complex procedure. You got someone moving the table, 4 more computers there, more people in the back. It is a very intense, one move and things go bad. We've got it down pretty smooth right now. This guy, Andreas Grunzig, in his Swiss apartment, developed the first balloon. He and his wife and the nurse were kind of using little soldering irons, and they made the first balloon catheter. At that time, open heart surgery in the 70s, Life magazine, it was the royal procedure. Everybody was just singing the praises. This could never possibly work. There is the first person that he did, where he had a tight blockage in the Widowmaker, and he dilated it open. I went to many of his conferences over the next several years. He would invite that patient to come in and talk, and the guy did fine for many, many years. He came from Switzerland. He was recruited by Emory and put on about 5 conferences every year. I'm hiding behind Mason Sohn somewhere back there, and a bunch of us would go and listen to this new amazing technology where you didn't have to have open heart surgery, where you could put a catheter in your groin, go up to the heart, and open up the artery. And when I was doing my cardiology fellowship with Ward Kennedy, who was head of the American College of Cardiology, we didn't know what a heart attack was. Nobody ever did an angiogram during a heart attack. It was felt that you would die. You had to wait 6 months. And he decided, I don't think that's right. And we set up a program. He ran it. I helped on a few cases where we would take people to the cath lab in the middle of their severe chest discomfort having a heart attack. And we didn't have balloons at that point, but we had this blood clot dissolving medicine called streptokinase, and we would dribble it in slowly over an hour or two. And so he published the article in, I think, in 83, and in 82, I came to town, and I was, enthusiastic about maybe following through. So this, I think, is the very first opening of an artery in all of Oregon. I had a 42-year-old fella who had a complete blockage of the artery right there. I put a catheter up the groin, and basically, this is what the blockage would consist of. It would kill the heart muscle there, and it'd be a blood clot, a scab. And I would inject slowly 1 milliliter at a time of this blood clot dissolving medicine. And after a half an hour, nothing would happen. I'd put a little dye and it would just stop. And then about 10 minutes later, his pain went away, his heart rate came up, EKG improved, and we had opened up this artery. And it was just an astounding, because it was something that wasn't thought of being done. But nowadays, we use stents. So there's 2 ways to open an artery. If you're over on the coast of Eastern Oregon, we'll give you the blood clot dissolving medicine because it's all we've got there. But if you're here in town, we will put a stent in to open that artery just as quick as we can. So what is a STEMI, an ST segment elevation myocardial infarction? It's the big heart attack when one of these arteries blocks off completely. So here's a picture of a normal artery, this one right here. Here's one that has a fairly tight blockage due to normally the artery is about the size, half the size of a pencil eraser. And this person, half of it is blocked off, but this person's perfectly fine. It's a very stable blockage. This person, however, that plaque is cracked and they're beginning to bleed into the plaque and they're beginning to form blood clots, which if it goes completely blocking it, then you've got a major heart attack like this. The artery is completely blocked. It's completely blocked with this. And our job is to get across it, suck out the clot, and put a stent in and reestablish flow, kind of like unkinking the garden hose. So we set up this program years ago. We had this feeling that there was a better way to treat heart attacks than blood clot dissolving medicine. Blood clot dissolving medicines only work about 50% of the time. And we had a number of people who would come from Grants Pass or Fairchild and Wairika. And by the time they got to us, they'd get the blood clot dissolving medicine, they'd wait 3 hours, it wouldn't open them, then they come down, and by then the muscle's dead. And we just figured out there had to be a better way. So we talked to Mercy Flights, we talked to AMR, we talked to the paramedics, and we said, would you be willing to ship your patients to us as quickly as you can? We talked to the hospital administrators, said, we have an idea that there's a better way to treat a heart attack. And back then, they were not Asante hospitals. Providence was independent, Three Rivers was independent, Fairchild Medical Center, National were all independent hospitals. They were all very willing to let us have their patients. And we communicated with the paramedics to do something that was not very typical. The 2 separate groups came together as one. We had Rogue Valley Hospital, which was doing the interventions, and we had the 4 other hospitals. You had Providence, Fairchild and Wairika, Ashland, and Three Rivers. We had a whole bunch of paramedic units that said, we're on board with this. And then you have hospitals in Eastern Oregon and Western Oregon. They're too far away to do the stent emergently. So they got the blood clot dissolving medicine, and then we air transported them as quickly as we could. If it didn't open them, we'd finish the process. So here's the history. When I started my cardiology fellowship in the 70s, finished in the early 80s, 0 treatment for myocardial infarction. 1 out of 4 people died if you blocked off an artery in the hospital. And then in the early 80s, we started using the blood clot dissolving medicine. And so the first thing that happened was a 25% mortality, like President Eisenhower experienced, with coronary care units and there's blood clot dissolving medicines. We got better. In the 90s, we got a little bit better. But in 2003, we and only one other place in the country, in Minneapolis, were saying, we think there's a better way. Good is good, better is better when it comes to your health. Open artery completely is much more effective. Death rates down to 3 to 4%. The rest of the country said, they're right. 10 years later, they made it a policy. So here's the very first study that we published. Rogue Valley Hospital, for every hospital is looked at for what their death rate in the hospital is when you have a heart attack. For years and years, in the 90s and 2000s, we were a top 100 hospital out of 6,000 year after year, because our death rate was 8.6%. The rest of the country was averaging about 12%. Some were worse, some were better. We started this program. We did every heart attack in Southern Oregon, Northern California. The overall death rate plummeted from 8.6% to 2.1%. If you walked into one of the outside hospitals, didn't call 911, but walked in, they would quickly identify it, call a paramedic unit, and take a whiskey on down I-5 right into our cath lab. If you walked into Rogue Valley, 0 out of 37 people died. But the more impressive thing was this. If you called 911, 0 out of 81 patients died. So we had this information. I hung on to it for a bit. I went to a major meeting and I talked to this guy, Doug Weaver, who was head of the American College. I said, we've been doing this thing down in Medford. And he looked at me. He was a big blood clot dissolving medicine, not a stent guy. And his jaw dropped. He said, you have to publish this. And I said I hadn't published an article in 25 years. He says, I will help you publish it. So we published it shortly later. So it was basically in 2003 here in Medford. It was an heretical approach to the treatment of a myocardial infarction. Paramedics would be able to diagnose a STEMI in the field and bypass the closest hospital and go directly to our laboratory where we would open it with a stent. Back then in 2003, the mantra was, you have chest pain, you get picked up by a paramedic and you get taken directly to a hospital. You go to the closest hospital so you could get the blood clot dissolving. We let these people then drive 50 to 60 miles past the closest hospital to come directly to us. We're waiting for them and rush them into the lab. A couple months later, I was invited to Washington, D.C., and Duke University was putting on a major talk with Mass General and Mayo Clinic and UCLA. The opening line of the conference here in 2007 was, we need to change the way we treat heart attacks. We need to do it the way they're doing it in Southern Oregon. And we published another article a couple of years later with us in a small community, LA, big communities, medium-sized communities, and they got the same results. And at that point, 2009, they said, this works. Now it's up to each community to figure out how they're going to do it. So this is our community. We're here at Rogue Valley Hospital, which has open heart surgery and stenting capabilities. A couple small hospitals on the coast, an ER on the coast. We've got Ashland Hospital. We've got Three Rivers Hospital. We've got Providence, Mount Shasta, Lakeview. Klamath Falls does their own. They've copied they have 4 cardiologists. They don't have open heart surgery, but they do their own emergent stenting over there, and Roseburg. And to put it in perspective, Klamath does their own, but if you're in the red area, you're going to come to us. If you're in this green area, which is 5,000 square miles, and you either call 911 or you decide you're going to walk into one of these outside hospitals, you will be diagnosed either in the field or immediately in the ER, and you will be immediately transported to the lab. We're waiting for you, and we race you into the cath lab and open the artery, because the longer that artery remains closed, the greater the chance you could die, or you'll lose your V8 engine will become a V6 or a V4 if it's a major blockage. And all of these facilities help transport them to us. Now let's compare that to LA. We have one STEMI center for 5,000 square miles. LA County, about the same as the green area. They have 88 hospitals and 34 separate STEMI units. I'll put our time responses ahead of theirs, so we have a very coordinated system here. So let me show you kind of a quick, exciting, this is my favorite case. This is a 51-year-old, perfectly healthy guy having breakfast with his wife on a Saturday morning up in Grants Pass, the restaurant, and suddenly starts with terrible heartburn. He's the color of, this. Wife is sweating. Wife throws him in the car, races to Three Rivers Hospital, doesn't call 911, just races there. Within a matter of minutes, they've got an EKG that shows the classic inferior heart attack. I know it's going to be an artery right here. They give us a call. They call the paramedics and go racing on down I-5. And we take them right into the lab. And here is the first picture. There's the catheter. There's the artery completely blocked, just like that picture I showed you in 1982, where the artery was completely blocked. Put a little wire, no bigger than your hair. You steer it across the blood clot, put it in the distal vessel, measure the vessel, go to the cabinet where we have all sorts of different stented balloons. They will open up in a kind of a tube-like sensation. You can have them 2.5 millimeters up to 4 millimeters in diameter, and lengths up to 33 millimeters, as short as 8 millimeters. You pick the one that works and you deploy it. You slide it across, you put it across the blockage, you deploy it, and you open it up. Look at the size of it. And total time, 65 minutes from the time he walked into Three Rivers emergency room at the triage desk to had the artery open here. I was up at Three Rivers yesterday at the celebration of their family house for families that need housing when they come for their medical emergency. It takes me 45 to 50 minutes to drive up there. So then we take a look at his other artery over here, and I'll just tell you it was wide open, but Bud's going to be able to tell me, Bud, what's going on here? We seem to have a problem. What's going on? Look, that's shotgun pellets. In a younger day, this 51-year-old kid got in the way of a shotgun in his 20s. So you never want to miss the opportunity to market your program. STEMI, get the lead out. So this process of coordinating the community and the patients and the paramedics and the cath labs and administration and nurses is probably the most complex procedure. It's complex, multidisciplinary, time-sensitive therapeutic intervention in the world of medicine today. The process is literally measured in minutes. The outcomes measured in mortality. Teamwork and transitions are absolutely essential. And this is kind of the stuff that's going through your mind. I don't remember all of this stuff. I have my you know, the people in the cath lab, some of it's their job, the nurse is their job. You got a patient with chest discomfort. They're not able to give much of a history. You know, from the EKG, they're struggling. Their blood pressure may be low. They may be having dangerous heart rhythms. They can't hardly give a history. The spouse can't hardly give a history. And you don't know anything about them unless something's in the electronic medical record. And you've got all these things you're balancing. And then we had COVID. And we continued taking care of patients the same way, where many hospitals switched back to giving the blood clot dissolving medicine. It's only worked 50% of the time. We continued to deliver it throughout COVID. We've not done a single blood clot dissolving medicine in Medford since we started this program in 2003. And we have the numbers. And there's all sorts of things that are we have all sorts of different stents and catheters and drills and lasers and coverage stents and machinery to look at how good a job do we need to do more. There's all sorts of different stuff. So let me show you what this is here. We can actually make a virtual picture inside the artery after we deploy the stent. Here we're downstream. Here's the wire that we put across. We're now pulling this device back, and here's the stent. And we can see if the stent isn't fully expanded. And we can put another balloon in and crank it up another 10 or 15 atmospheres of pressure and grip that stent into the wall, unkink the artery. We have kind of auxiliary, but so let's look at some of our statistics. Compared to the rest of the country, the further to the left you are, the better you are compared to every other hospital. Here we are with our heart attack mortality at 1.35% for this particular quarter. That's in the top 5% for the entire country. That's all the big medical schools, all the big training centers. We're every bit as good as them. If you do an elective stent, somebody who's not in the middle of a heart attack, but is just having chest discomfort every time they walk up this flight of stairs, look at where we are. We're probably, for mortality, probably in the top 2%. We also, congestive heart failure, where just the heart doesn't pump as well. That's the most common reason people are admitted to the hospital today. We had the 4th lowest readmission rate at 30 days. Here's some of the awards that we've won. This was an interesting one. The hospital systems out of, let's see, 324 healthcare systems, 10 years in a row, we were voted a top 15. Only one other place in the country that has a record like that, someplace you probably never heard of, called the Mayo Clinic. Top 100 hospital. These are our heart attack awards and many other awards. And this one I'm probably most proud of. In those years right there, out of the 951 biggest, most comprehensive heart centers in the country, we were in the top 50 multiple years in a row. Things are changing. The medical knowledge back in the 50s doubled every 50 years. In 2020, every 73 days. It's probably changing now every 2 weeks. The amount of it, you can't possibly read and recall. And as soon as you've learned it, things have changed and moved on. Everything is moving on to AI. And I have 2 kids. Both of them are basically running, one's running ChatGPT medical program for the world, and the other's running Copilot for Microsoft for the world, the medical system. Meanwhile, their father struggles to enter a new name into my contacts list. So here's Rogue Valley Hospital circa 1956. And here it is today. Pretty impressive change. It's been a real honor and just an exciting run for me doing cardiology here and just to have a wonderful group of people that are totally dedicated to staying at the top of their form to take care of you or a loved one who gets terribly sick. And I'm willing to stick around a little bit later if people want to talk. If there's time for questions now. Go ahead. Waiting for him to walk up.
And get a colonoscopy and other things that are sort of looking at potential problems. You're solving problems when they're well identified. Are there preventative stuff? Can you do, would the people in this room profit by having scans of their arteries?
At this point, no. In fact, it's proven what happens is you do scans, you find stuff. Our hair gets gray. Our hair disappears as we get older. Getting atherosclerosis is a common problem. It's just like we get arthritis. Finding it is not a problem. Stabilizing is what's important. So exercise, eating properly, treating your diabetes, treating hypertension, treating your cholesterol, not smoking. Those things all work. Finding an asymptomatic blockage does not make you better. Yeah.
Dr. Gross, thank you so much. You know, you've been a great asset to this valley. I know it's hard to find doctors to come here because of this program. Does that make it easier because they're excited about being part of it, or what's the recruiting process and how's it going?
Yeah, it's not easy anywhere. I mean, there's a shortage of physicians, a shortage of nurses, but especially physicians. You know, people, I had never heard of Medford. I was up in Seattle. I was an assistant professor of medicine. I've just met my wife, who was the head nurse in the CCU, and John Forsythe's best friend at the time was one of my mentors. He said, you ought to go, John wants to start a cardiac program in the old Medford clinic. Where's Medford? Okay, there wasn't, you know, you didn't have phones where you could look it up. You needed a Texaco map or something to find it. So I said, all right, I'll go on down. I met John in the airport at 10 o'clock at night. He had parked out there by KOBI's dirt parking lot. And with none of this, you didn't have to pay or anything. And before I left the hospital, I just knew I wanted to practice medicine with him. I'm so proud of the people that we've got 5 interventional cardiologists right now. One of them, for instance, here, Alyssa Corley, we just hired her 2 years ago. She has a little bit of a good CV. Let's see, she went to Pomona and she was an All-American catcher there. And she went on to Dartmouth, where I did my internship residency. She did her med school there. Then she went to the Beth Israel Mass General Hospital for her internal medicine residency. And then she went to Duke for her cardiology fellowship and then additional training. I mean, this is a top-notch person. Can't doubt of it. Awesome. Just trained at Cleveland Clinic. We have a superb group of interventional and general cardiologists. Any one of them could take care of me. And that's what you want. But when I leave, I wanted to make sure that I left when they were sorry to see me go, not relieved to see me go. And that should be true for everybody when you retire. But any one of them could take care of me if I have a heart problem. And I would tell you that with that kind of core group, we've got 2 more coming this year because Dr. Moran and I have just recently retired. And we've got 2 more already set up, potentially coming for interviews. But it's hard, it's difficult. But having a program like this certainly enhances the capability. Well, it's basically they train in big centers. And so anybody who kind of really stands out, someone locally say, hey, you don't even have to move. We want you in this group here. And they don't know about us. Okay. And I didn't know about Medford. It's just an incredible place to live. I mean, you know, you've got 4 seasons, you've got rivers, you've got fishing, you've got golfing, you've got running, you've got mountains. That's all right here. And we're isolated. You know, we can do like this STEMI program. It would have been very hard to do that program in a big city because you had all these competing groups. Oh, you can't take that patient. They belong to me. You can't have this. No, that's not policy. It was kind of a 1980s. There weren't a lot of guardrails on stuff. We could do what we thought was a reasonable thing, and we followed it, and it worked. If it didn't work, we would have stopped. But, yeah. And there's a lot of places. I mean, there's an awful lot of places that everybody gets heart disease. It's the most common condition. And so people can get attracted to it. Some people want a big city. We've got great, there's this St. Mary's program we're talking about, great schools, great opportunity, outdoor living without the frustration of living in a big city, as far as I'm concerned.
Great cardiac, programs and things. Most, back in the day, you would go see a doctor, but now you see an NP or an FNP. Are those folks pretty engaged with saying, oh, you got a leaky valve? Most people do. Don't worry about it. I mean, are they really engaged for the most part? Because
Sure.
it seems like they're kind of all over the map.
It's not here. It's everywhere. Okay. The reality is to do what I do is 15 years of post-high school education, more than kindergarten to 12th grade, between college, med school, residency, and specialization beyond that. 15 years. For a nurse practitioner, it's 6 to 7 years. But it's 20,000 hours of clinical work for a cardiologist. It's 1,500 to 3,000 for a nurse practitioner. They are very good doing, spending time, very focused on if you're a nurse practitioner in the office, if you're a nurse practitioner for dermatology, they are excellent. They know their field very well, but outside the field, you need to have somebody who's more specialized. Okay.
Thank you, Dr. Gross. Before you leave,